Thank you very much for the kind invitation. And I'm going to share with you our experience with remote monitoring. And this talk comes on very well after my talk, the talk by my colleague, Dr. Bradley. So what is remote monitoring? Remote monitoring is a collection of digital tools and systems. And we heard some at this meeting. The aim is to monitor and manage our patients remotely and utilize patient-reported outcomes, blood tests, and telehealth services. The promise of digital has been great that we'll solve all our problems in NHS because we'll have people communicating with us through their smartphone with good coverage of 5G, and then this will be interacting with our EPR system. It'll all be very nice and smooth, but in fact, it's not so smooth. And this partly down to the adoption of our digital technologies, and you're very used to the work by Everett Rogers in the 60s about the innovation diffusion theory, why things that sound so good take so long. There's this chasm that we have to get through. All of you here were clearly the enthusiasts and the visionaries, but once we leave this place, we will face challenges outside, and it is our role to articulate the benefits of such IT technologies and to be leaders in the place where we work to try to transform the care that we deliver. And my talk is going to be divided into three parts. Firstly, to describe the digital technologies, what they are. Secondly, to review the current healthcare situation. And thirdly, to share with you some real cases of how we've deployed such digital remote technologies into our clinics. So this is the latest report, hot off the shelf. This is the state of rheumatology in the UK. This is the National Early Inflammatory Arthritis Audit, published by the British Society of Rheumatology. And these are the clinical standards. These are over 5,000 patients recruited across the UK. And you can see that on average, only half of these patients are referred within 3 days of them seeing their GP. It means that the GP is not confident yet, not confident in spotting whether this patient has got rheumatoid arthritis, and they take a long time. In terms of getting the appointment, only 44% are seen within the target of 3 weeks. Now, this is a capacity issue here. Not only is the referral slow, the time to see them after getting the referral is also slow. And once we see them, only 60% of the times are we starting the treatment, which is disease-modifying drugs, within 6 weeks. And over 3 months, only a third of them ever get into remission. Now, this tells us there's a bit of knowledge gap in primary care. We have to work on that. Secondly, there is a capacity issue in seeing people, and also the provision of services in order to start these drugs, because these drugs require monitoring, they require setup. So this is the situation. So rheumatology is, like many other long-term conditions, a condition where once you diagnose somebody with rheumatoid arthritis, you're going to have to stay with them for the rest of your life or your career. The only time they leave you is they move out of area or they pass away. And that is a bit slower than the number of patients that come and see you. And it's also the number of patients that come and see us is quicker than the rate that we can employ more rheumatologists and nurses. So we will face this coming wave of an increasing number of patients coming to our clinic year upon year. As we see new people, they are not going to get discharged. And so we have this slowing down of the system, I call this slow, where we get to a stop at the end and the waiting list starts to come up and we struggle to see our patients. There does not seem to be any useful release valve or a way of managing these patients. And increasingly, we're asked to do more. We have to fill in more forms. And this is what I call mission creep. There's more and more things you've been asked to do on what is already a very saturated system. So we thought about remote monitoring back in 2018. And what is the evidence base? Here is a recent meta-analysis that shows all the papers. And you can see that going above the line 1, the remission rates or low disease activity is better if you do regular patient-reported outcomes. These are asking people about their well-being, their score, their pain level, their fatigue, and their sleep. If you do this regularly, goes back to the quote by Lord Kelvin that if you can measure something, then you can make some change. If you can't measure it, you can't make a change. And this is on the meta-analysis as well. It shows that if you do these things, you have fewer face-to-face visits. The clinician and the patient are more confident that their condition is being monitored and are not seen as frequently as if you don't do regular measurement of their outcome measures. So we believe that we want to change that earlier graph that we showed you, that earlier pathway, to this. And this is our long-term vision in our rheumatology department over the next 5 years, is to slowly implement these systems into each part of this pathway, where you have heard today about the early detection of the GP referrals, that's at portal of entry. But once they come in, we are thinking of what will be the right digital solution. And we have adopted blood analytics using our Dawn system. We've implemented electronic patient reported measures. And now we're also working on how we can predict if somebody may have a flare of their disease. So these patients are not all the same. They may flare at certain times, some may remain stable. So we have to decide how we see, who we see first, and when we see them. So firstly, talking about the electronic patient reported outcomes, we have doctor in the NHS. So we asked them whether it's possible to send these questionnaires to people prior to their clinic and base that on the SMS or text messaging or email. And so we worked over the last few years to implement this. And you can see we can order this on our electronic patient record. The patient will have a score that is completed, and that score is completed before they come to clinic. And so now in clinic, we can talk about the score. We can find out how they've been in the last 6 or 9 months when they didn't see us. In the past, we only did that score when they came to clinic, and that took a long time, and it was kind of eating into our clinical time, and we didn't really find that beneficial. And in the long term, we'll be able to, over time, review their clinical status, what they like when we're not seeing them. And this, if you like, is a safety net, a security net for both the patient and us, that we are talking to each other in some useful, objective, validated way to monitor their situation. So here is some scores that we have. We have developed these scores. These are validated internationally and used in clinical trials, and also we are using it in clinical practice. And we have modules of psoriatic arthritis, rheumatoid arthritis, and also ankylosing spondylitis. We realized that this will only be reviewed if it's in the electronic patient record. If this sits in an app somewhere or some database somewhere, it will not be reviewed, which poses a governance issue, and also it'll never be up to date because people are not renewing the scores there. So this is done by them through doctor, and they get fed back into our electronic patient record. We can order it from EPR, we can review it, just as how we would look at a blood test result. We can see this next to our full blood count. We can see these outcome measures. So this, together with the imaging, together with the blood test results and the electronic patient record, starts to build up a richer picture of what the patients are like when we're not seeing them, or when we come and see them, we are a bit more prepared to discuss what are the important bits of their condition. So this is our, up to August this year, this is the 2-year data, how many forms you have sent out to patients, and how the number of patients in need of this category. And the completion rate is about 60 to 63%, which is good for something that is being sent to you regularly. I would ask you how many times you would complete a survey after you have flown your airline or been to shopping. Probably not, unless you have something to complain. You want something back, then you may complete it. So we're asking people here routinely to do this every 3 to 6 months. And so in the literature, this is a good result to get 60 to 70% routine completion of a questionnaire. So from these questionnaires over time, we have developed a dashboard. So this is taking one of the scores called the BASDAI score, which is a validated score for ankylosing spondylitis. And over time, we can see what our performance is. So we have people now classified to being high disease activity in the top bar, moderate disease activity, and those in remission. So we can start to say, how do we schedule these people's appointment? So some in the top one, we clearly want to see them first to bring down that bar. So these would be our face-to-face appointments that we'll book in the next 6 months. Those in the middle, we could have a telephone or video consultation. Because they are moderate, it might be that we just need to review them. These are follow-ups. And finally, the third one, they are very stable. They probably don't want to come to hospital if they don't have to. We put them on something called patient-initiated follow-up, where they generate the follow-up call if they need to be seen, rather than us giving them timely appointment. And over time, we can see what our performance is and whether we are hitting the targets that are set for us nationally. So in the previous pathway, we used to see people on a regular basis. This was the only way for us to stay in touch with our patients. We see them every 3 or 6 months. As we showed earlier, that will lead you to a backlog in no time, because every new patient becomes clogging up the system and it gets filled up with your follow-up slots. So in the new system, because of remote monitoring, we can now give people a longer follow-up. up to 2 to 3 years, but they're never discharged because the GPs will not want them back. But we monitor them in a remote setting, and they can still contact us if they need to be seen, either by change in their scores, the blood test or the PROM score, or they phone us. So they can override the system if they feel that there is something they want to see us. And that percentage of coming back is very small. In a year, only 10% of these people who used to come regularly ever came back. So 90% of the time they are being monitored remotely. And so what would be the metric to this? How would you know that this investment would be useful? So one metric that we use is the new to follow-up ratio. How many new patients do you have get converted into follow-up within a year? And in the Royal Berkshire, we've been managed to work to get this down to 2.5. So every new patient has a 2.5 follow-ups. And that is below the national average. The recent Get It Right First Time GIRF report reports the national average is 4.2 in the UK, and some trusts up to 10. So that is clearly going to clog up your system much quicker than if we ran a lower system. Now, year upon year, we are still seeing new patients. So to keep it like this, we just have to maintain this system and allow us to see new patients, also manage the follow-up patients. Remote blood monitoring is another part of our remote monitoring pathway. We use something called the 4S Dawn, which you heard a little bit about earlier. And this is because our patients require regular blood tests. And in the past, our nurses would log into the pathology system every morning and check routinely. But when you got to 5,000 patients, that's no longer possible. Neither is it safe to expect someone to check that every day. So now we have an automated system where parameters can be set. So if somebody falls out of a parameter, the system alerts you. If they're normal, then they stay within the normal list. But also we can find out if patients don't have blood tests, the DNA, and also then we can contact the patient and GP to see what exactly is happening. And often this can prevent the actual flare, or this can prevent the attendance in A&E, because we can intervene much quicker. It might be that they have an infection. It might be they need a dose escalation of their medicines or dose reduction. It works on a hub and spoke model, so the patients do not come to hospital. Everything is done in a community. They have their blood tests wherever they can. That gets fed into the system, and then it comes back out, which is linked back to our electronic patient record. But more interestingly, I was interested to look at trends within what we call normal. So here is a patient. She's a lady with rheumatoid arthritis. She's age 60, and she tells me I'm doing okay in the first part of this graph. And in the red box, she phones and says, I'm not feeling so good. I'm feeling a bit fatigued. My joints are hurting a bit more. But in all this time, her blood test is in the normal range for most of this time. And you can see some peaks, but there's not been any big change. But physiologically for this patient, although they're in the normal range, there has been abnormalities in their counts. And so we have noticed this change, and then we have made an intervention, and then she feels better, her scores improve. So there is also what we're doing is the analytics within the individual patient to look at biochemical changes, physiological changes that may signify the worsening of the disease outside what we come to know as the normal range. So the next question was, can we develop a machine learning model to predict flares of disease? So over time, we've accumulated a lot more information. These are the things that we can now gain from electronic patient record, our GP record, and blood counts and blood results. We also measure people every time they come to clinic. Not only in our clinic, if they came to another clinic, we have weight and height measurements. So putting all of this together now with a larger data set, we ask ourselves, other than what we know of doing electronic records and patient record and blood tests, could we actually predict that if a patient may have a flare prior to them having the actual event? So working with Pradeep and Professor Lee, we have been working on this model in the last few months, where we have cleansed the data to make sure that these patients truly have a flare. We have something called a flare clinic, where the patients are coded to have a flare, and that needs to be verified that that's what a flare is, a worsening of their clinical status, a worsening of their disease activity, and then collecting this data, then using machine learning, light gradient boosting mechanisms, and then developing an area under the curve to predict whether the patient may have a flare, and then secondly, doing the training and testing set, and then retraining the model to develop a flare prediction tool, and finally using explainable AI to look at the determinants on the Shapley plot. So this has just been presented at the American College of Rheumatology this week in Washington with some very good feedback, and we'd like to develop this further. So I'm just going to show you some early results. This is still work in progress. This is one group, the Axial Spondyloarthritis group, Ankylosing Spondylitis group, and I can take you to the area under the receiver operating curve. We are performing fairly well in this area, and the accuracy is also above 0.8, and sensitivity and specificity as well. We have looked at different time points to see how far ahead can we predict this. We started off with, say, 9 months, but obviously coming closer to the event, the accuracy improves. And this allows us now to think about these patients who are at risk of having a flare. It's one more thing that we can add to our pathway to try to manage our caseloads better. When we look at the determinants, there are quite a few determinants, and these are the aggregated scores on the Shapley plot. And you can see that drugs are quite important. The changes in drugs in the GPs might be prescribing them more anti-inflammatories, pain medication, and that could be the sign that they are actually starting to flare. There could be comorbidities such as diabetes, hypertension. Those require management as well. And then down here we have more scores, including the small changes in the blood tests down at the bottom, which may not weigh so much heavily, but once we start analyzing within that normal range, we may see more information. Where do we want to go with this? So where we started by using what is patient-reported outcomes, blood test results. We wanted to come to a place where we can start predicting a bit better to manage our patients, and eventually to come to people who are at risk and people who are not at risk. And then it still requires a clinician check with this. We like to see this as a virtual assistant, because at the moment we are booking based on a guess game. We can say 3, 6, 9 months, but it's purely just on our kind of sixth sense, which is also quite important as a clinician. That's quite important, your gut feeling. But hopefully this can supplement that in order for us to be a bit more accurate if we can. And for those who are at risk, then probably those who need timely review, intensive management, maybe escalation of their treatment, management of their comorbidities, looking at that, and also how we can prevent the flare. And then there's this whole kind of drive to not see people as much, and the not at risk group that we can calculate and try to identify will be more suitable for this type of management down here. And so we can get a bit better by using the data. And eventually we want to look at other things. So firstly, wearables. We are discussing how we can use wearables as a next bit of information. We can measure people's steps, we can measure their sleep at the moment, but we also want to put on things on their joints and also their spine to see their movement. So we are discussing that at the moment. We're also looking at point of care testing, good discussions yesterday about how we can do some of these kits at home. And this could be another thing that could be add on to our remote monitoring program on top of the scores that we have and some of the other measures that we have from the blood tests. So putting it all together, we hope that eventually we will get to a more personalized care for our patients. Clearly, one size doesn't fit all. Our protocols and pathways are written to as if everybody's the same, and our offer to them is all the same, but we are going to try to change that to be more individualized for the patient based on the information that we have. So I'm going to summarize and close by 3 words. Firstly, that chasm that we talk about in the innovation diffusion theory, we kind of see this as closure, trying to close that gap by our colleagues and our patients seeing the real benefit of remote monitoring. It's better for our patients, it's better for our clinicians. We're having a better discussion now looking at these data rather than trying to get the data, greater patient involvement. Secondly, leverage, trying to lever these digital technologies and remote monitoring tracking into our patient so that we can try to be a more sustainable service in the long term. And finally, to get the traction, to find that this is sustainable and useful for our patients and our clinicians in the long term. So I'd like to thank all the collaborators here in Henley who've worked together with me and colleagues in my rheumatology department, and also for our funders. We have some upcoming work that we hope to kind of develop this in more detail. So thank you very much.